Hey guys, today I'm going to be talking about pain management. This is a general approach to pain management in the inpatient setting. So, the first thing is to get a comprehensive pain history. What is a pain history? Basically, the goal is to maximize the level of functioning and quality of life. So, the important thing is to get a complete history of the events that trigger the pain, figure out what the level of the pain is and how the pain interferes with the patient's daily functioning and quality of life, and review prior diagnostic evaluations of pain and treatments. The most common tool to rate the pain intensity is to ask the patient, how would you rate your scale of pain, how would you rate your pain from 0 to 10, 0 being no pain to 10 being the worst possible pain. You can give them a visual scale. This is the visual analog scale where it shows you the different types of pain and their associated like facial emotions. So this can help the patient figure out how bad their pain is, and so that they can give you an accurate reading. Another thing is, let's talk about mild to moderate pain. So for mild to moderate pain, non-opioids and adjuvants are recommended, such as acetaminophen 4 grams daily. 2 to 3 grams is safe in liver disease. You can also give NSAIDs. Caloxibib is best if there's increased GI bleed risk. Ketorolac if severe pain, 10 to 15 milligrams is recommended. You have to use NSAIDs in caution with patients with coronary artery disease, renal disease, and inflammatory bowel disease. So another thing to remember is for moderate to severe pain, you can schedule non-opioid options. You can try topical medications and then consider short-acting opioids as needed. So for severe pain, this requires round-the-clock opioids. You can discuss this with the attending and consider adding extended release meds. You avoid extended release opioids if the pain source is expected to resolve, such as a bone fracture, hematoma, abscess, or post-procedural pain. It's important to identify what kind of pain your patient is having. So somatic or musculoskeletal pain is easily localized. You can usually touch the area and it'll be sharp, aching, and gnawing pain. The bony pain can be treated with high-dose NSAIDs or steroids. You can also consider palliative radiation therapy if the pain is cancer-related or due to surgery. For muscle spasms, you can use topical lidocaine, caspacin, methyl salicylate menthol ointment, muscle relaxants such as cyclobenzaprine, baclofen, tizanidine, and watch out for sedation and delirium. For visceral pain, this is pain in the deep tissues and internal organs. It's vague, referred, or difficult to localize. There will be visceral distensions such as hepatic capsular stretch from liver metastasis and malignant bowel obstruction. This depends on the etiology, but steroids can be helpful for steroids can be helpful for visceral pain. You can consider plexus block with patients with chronic pain. The next type of pain is inflammatory pain. This is associated with other signs of inflammation such as swelling, erythema, and warmth. For this, NSAIDs, systemic or topical, can help, or steroids can help. Another thing to remember with steroids is that in cancer patients, this may interfere with the treatment, such as immunotherapy and/or diagnostics. If there's a prolonged course of pain, you'll need GI and PJP prophylaxis. Determine who will manage the taper plan at discharge. This is specifically referring to steroids because long-term steroid use can cause immunosuppression. So long-term steroids is typically not used, and you need to taper the steroid plan so that they eventually get off the steroid use. Nobody should be placed on chronic steroids unless you have a medical indication for that. So another thing is neuropathic pain. This is burning, stinging, or allodynia, or hyperalgesia. What is allodynia? This is pain in response to a normally non-painful stimulus. For example, you touch a stroke patient and they give you lots of pain report. So that's allodynia. Hyperalgesia, this is an exaggerated pain response to a stimulus that is normally painful. To treat this, topical treatments such as caspacin, camphor, and menthol, lidocaine, or diclofenac gel can be used. Remember to go low and slow in older adults. And then we have non-pharmacologic therapy. This is such as PT, physical therapy, exercise, activity, heat or ice, cognitive behavioral treatment, treating comorbid psych diagnoses, massage, acupuncture, and other integrative therapies. And we have pharmacologic agents. So I'm going to talk about all the pain medications now. So for neuropathic pain and opioid sparing analgesia, remember neuropathic pain is the burning, stinging, allodynia or hyperalgesia pain. So for that, you can use these different agents. So I'm going to talk about the alpha 2 delta ligands. These are the first line options, especially those with a history of seizure disorders or contraindications to antidepressants. The side effects include dizziness, somnolence, which is basically drowsing off into sleep, drowsiness, and peripheral edema. So the alpha 2 delta agents or gabapentin, you can start with 100 milligrams orally 3 times per day as an initial dose. You can increase 100 milligrams TID every 3 days, and the max dose is 3,600 milligrams a day. You can adjust the dose for renal function. Then you have pregabalin, which is 75 milligrams BID or 50 milligrams TID. You can increase by 50 to 150 milligrams per day within 1 week if tolerating, with a dose range of 300 milligrams per day in 2 to 3 divided doses. Also, you have to watch out for the creatinine clearance, adjust for that. And this is more easily absorbed. Next, I'm going to talk about the SNRIs. What is that? That is serotonin norepinephrine inhibitor agents. So this basically increases the amount of serotonin and norepinephrine in patients, and is preferred in patients with comorbid depression or anxiety. The adverse effects include nausea, dizziness, and fatigue. So the agents are duloxetine. You start with 20 milligrams daily, increase by 20 to 30 milligrams per week with max dose of 20 to 60 milligrams per day. The common side effects include sweating and avoiding if creatinine clearance is less than 30 milliliters per minute, preferred for painful diabetic polyneuropathy. Then we have venlafaxine, it's also SNRI. You can start with 37.5 to 75 milligrams daily, increase by 75 milligrams every 4 days, max dose of 225 milligrams per day. You need 4 to 6 weeks for the effect. And there's also a risk of withdrawal symptom when stopped, and this needs a taper. Then we have the tricyclic antidepressants. These have the most efficacy but carry anticholinergic effects such as dry mouth, constipation, and urinary retention, and cardiac risk such as QT prolongation. The common intoxication syndrome of TCA is, for example, a patient who has these at home and they have suicidal ideation and they just take the whole bottle of TCAs. They will have convulsions, coma, and cardiotoxicity. Amitriptyline, initial dose is 25 milligrams at bedtime, 10 milligrams if they're frail and elderly. You can titrate the dose every few days with a maximum dose of 25 to 100 milligrams at bedtime. This is the same with nortriptyline. This allows, you need 2 to 4 weeks for effect, and there's less side effects with nortriptyline. Next thing I'm going to talk about is ketamine. So you can start ketamine administration. This requires palliative care or chronic pain service. Psychiatry can also do this. So you can consider ketamine if 1, you're experiencing severe post-operative pain such as abdominal or thoracic surgery or orthopedic surgeries. 2, if they're opioid tolerant patients presenting for surgery or acute pain exacerbations. 3, if the patients are at increased risk for opioid related respiratory depression. And 4, if they have opioid dependence. The adverse effects are rare at sub-anesthetic dosing, such as hypertension, tachycardia, arrhythmia, hallucinations, increased intracranial pressure, increased bronchial secretions, and nausea and vomiting. The psychomimetic effects are effects of the drug-induced psychological states of psychosis. A common thing to remember is this was used as a horse tranquilizer in the past and can cause states of dissociation and dissociative states. Recreational drug users of ketamine will use this to escape from reality, but this could be used clinically the patients having severe pain that's not tolerated with oral or IV medications of different class medications. This can be treated, this psychosis state, by 0.5 milligrams to 1 milligrams IV haloperidol or 1 to 2 milligrams IV lorazepam. You can avoid ketamine if they're poorly controlled cardiac disease, pregnancy, if they have any active psychosis or hospitalization history in the last 3 years, any severe liver disease, and any increased intracranial pressure or intraocular pressure. I think this hospitalization history refers to psychiatric hospitalizations. But next thing I'm going to talk about is opioids. An important thing to differentiate is what is opioid naive and what is opioid tolerant. An opioid tolerant patient is one who is chronically receiving the medications on a daily basis and has developed an adaptation requiring higher doses to maintain the pain relief. So this is defined as total daily dose times 7 days with this opioid equivalence. So morphine 70 milligrams daily, oxycodone 30 milligrams daily, hydromorphone 8 milligrams daily, fentanyl 25 micrograms per hour. So how do you do this? Calculate their total daily dose times 7 days of the opioid equivalents and see if it matches these levels. If it's less than that, then they're opioid naive. If they're more than that, then they're opioid tolerant. So patients on buprenorphine or methadone for opioid use disorder or active non-prescription opioid use disorder, you treat the pain with full agonists if needed. So basically you give them the medication even if they have opioid use disorder in the inpatient setting. So you can consult the acceptance and commitment therapy. You can avoid using combination pills. So these are the different doses of the opioid medications. You could go ahead and pause the video and take a look at this. But now talking about methadone. So methadone is beneficial in neuropathic pain with 3 times dosing for pain. Cannot be converted linearly from other opioids as it has a long half-life and can cause QT prolongation. It takes days to reach the steady state. So another thing is for safety, if the patient is having a fever, you can reduce the dose or remove the patch. This is also less effective in cachexia due to lower subcutaneous fat for absorption and requires 18 to 24 hours to reach the therapeutic level. A fentanyl patch is safer in both liver and renal dysfunction. You need to initiate with chronic pain or palliative care consult and ensure that there's an outpatient prescriber at the discharge. Another thing is if they don't have a PCP appointment scheduled, this could be very harmful for the patient because if they happen to run out of their medications, especially if they're on a medication like fentanyl, which has a very strong potency, then they can go into acute pain crisis and it could be very harmful to the patient. Remember, pain can cause systemic effects such as fever, hypertension, and basically it's as much a risk as getting lower doses. For opioid uptitration and rotation, so if the pain is only moderately controlled with scheduled doses, you can increase the total daily dose by 30 to 50%. If taking extended release opioid and needing greater than 3 to 4 rescue doses, you can increase the extended release dose by 50 to 100% of the total rescue dose in the past 24 hours. You can also rotate the opioids if there's side effects and reduce the dose by 25 to 50% when rotating. So let me give you an example of how this is done. Basically, if a patient takes morphine extended release 60 milligrams orally every 12 hours, plus or minus morphine immediate release of 15 milligrams orally twice per day. So first thing you want to do is calculate the total daily opioid requirement and calculate into morphine equivalents. So there's a table for that. You figure out what the morphine equivalents are and how much they're taking on a daily basis. Then you convert the total daily dose to equivalent dose of new opioid. Then the next step is to reduce the dose by 25 to 50% to account for incomplete tolerance, and then divide the total daily dose by number of doses per day. So if they're starting a long-acting opioid, you can divide the total daily dose into extended release doses and add a breakthrough dose that is 10 to 20% of total daily dose of the extended release opioid. So how does this work? Here's the example. Basically, this patient is taking morphine extended release 60 milligrams orally. We already talked about that. You basically figure out what the total daily dose is, which is 150 milligrams morphine, and then you divide that by the oxycodone equivalent. So the ratio is every 30 milligrams of morphine is equal to 20 milligrams of oxycodone. So 150 milligrams of morphine is equal to 100 milligrams of oxycodone. So now you have 100 milligrams of oxycodone. You decrease that by 25 to 50%. So basically give them like 60 milligrams oxycodone. Okay, so then oxycodone divided into extended release and breakthrough pain. So they have 60 milligrams divided into 2. So oxycodone extended release 30 milligrams every 12 hours with 10 milligrams oxycodone every 4 hours for breakthrough pain. What is breakthrough pain? Breakthrough pain is basically an exacerbation of pain that takes place while the patient is on the medication. Okay, so we talked about that example. Here are the morphine equivalents, so you can go ahead and pause the video and take a look at this. But okay, let's talk about pain crises management. So this is a severe worsening of the pain, and while treating, it's important to pursue the reasonable workup for the etiology. The goal is reduction in the pain score by at least 50%. So if they're in sickle cell crisis, you let the patient guide their therapy and their acute care plan. If they're opioid naive, you give morphine IV 2 to 5 milligrams hydromorphone IV, zero point 0.2 to 4.4 milligrams bolus. For opioid tolerant, convert the usual breakthrough dose or 10 to 20% of the total daily extended release to IV and administer. You can assess the patient for response after 15 minutes and see if there's a response. If there's no pain relief and no side effects, you can increase the dose by 50 to 100%. If there's minimal relief and no side effects, you can repeat the same dose. If the pain is reduced greater than 50% and no side effects, reassess in 2 to 3 hours and use this dose as the new breakthrough dose. The side effects with no pain relief, rotate to IV opioid. So what am I saying here? I'm basically saying you give the IV medication or oral medication and you basically see the response after 15 minutes. Based on the response, you can titrate or reduce based on that. All right, patient controlled analgesia. What is that? So basically this is a pump connected to an IV that allows the patient to dictate how much pain relief they get. Another thing to remember is families cannot use PCA by proxy. So if a patient is like unconscious and they have a PCA that's connected, the family cannot give the opioids. That's just a liability issue. But another thing is patient-controlled analgesia basically requires a daily delirium assessment. Go on a segue here. How do you do that? You can either use the CAM or 4AT score. The CAM is like more sensitive, but the 4AT score is quicker to use. So CAM, basically you assess 4 things. 1, acute onset and fluctuating course of mental status changes. Basically any acute mental changes in the last 24 hours. Any inattention or inability to focus. 3, any disorganized thinking. Or 4, any altered level of consciousness. So delirium is present when features 1 to 2 are present, plus either feature 3 or 4. Okay, so let's talk about the 4AT score. So it's basically quicker to do. What is it? It's basically, is a patient, I didn't write it here, but this is the 4AT score. The 4AT score is alertness, attention, abbreviated mental test, and acute change in mental status. So if they have greater than 3, so basically each one of those A's is anywhere from 0 to 3 points. And if they have a score greater than 3, it could be positive for possible delirium. So let's talk about that. You got 4 aspects: alertness, attention, abbreviated mental test, and the acute change in mental status. And each one of those has a score of 0 to 3. If they have a total score of 3, it's possible for delirium. Okay, so PCA enables I already talked about that. So there's a general PCA delivery, and then there's for opioid naive, and then there's a opioid tolerant, which gives you a rate that you can have a basal rate of the opioid. Basically, if you're opioid naive, you don't get a basal rate of opioid. If you're opioid tolerant, you get a basal rate. So why is that important? It's because there's a steady state concentration of opioids in your blood. And if you have a basal rate, that it can increase the steady state concentration of your blood. If there's a nighttime awakening of pain, you can increase the basal rate at night. And this, you could pause the video. This is what PCA, general opioid naive dosing is. So let's talk about the last thing, is the adverse effects of opioid use and management. So here are the adverse effects. You have respiratory depression. So basically a patient can stop breathing. What you want to do is you can dilute 0.4 milligrams naloxone and 9 milliliters saline, and you can give over 2 minutes, 1 to 2 milliliters, and you can do it until their respiratory rate improves. And you have to watch out for recurrence of respiratory depression once the naloxone is stopped. You can consider the naloxone drip if the patient has respiratory depression. Another thing is constipation. It's important to do Senna or Miralax. You can give methyl naltrexone daily if failed the laxative therapy. You can rotate the opioids, involve palliative. Then you have myoclonus, which is basically twitching of the muscles. You can reduce the dose or rotate opioid. Basically, if the patient's very symptomatic and they're complaining about this, you can rotate the opioid or reduce the dose. You can increase the hydration. You can give low-dose benzodiazepine, baclofen, or gabapentin. If this persists, you can consult palliative care. If they have nausea, vomiting, you can start prochlorperazine, I don't know how to say that, metoclopramide, haloperidol, or low-dose naloxone drip. You avoid ondansetron due to constipation. If they have pruritus, this is mediated by the mu receptor. So basically, you give ondansetron or nalbuphine 5 milligrams IV every 6 hours, or low dose naloxone. If they have sedation, you can use a stimulant such as dextroamphetamine, methylphenidate. If they have delirium, you could reduce the dose or rotate the opioid. IV Haldol 1 to 2.5 milligrams BID or QID for IV, or IV PO Zyprexa 2.5 to 5 milligrams PO